Good evening, everybody. Welcome to this evening episode of Pursue. And this is Pursue 1.0, which is Uropathology. And we are streaming live from Kolkata. And we have a continuation of the cystic and dysplastic lesions of kidney. This is session 2. And to continue with session 1, we have Dr. Mitadru De Sarkar. He's an MBBS from JIPMER, MD from JIPMER. He's a consultant histo and cytopathologist, laboratory head, overall quality in charge of Calcutta Heart Clinic and Hospital, Kolkata. He's an ex-assistant professor of the Department of Pathology, SMV Medical College and Hospital, and also an ex-consultant pathologist of SRL Diagnostics, Fortis Hospital, Anandapur, Kolkata. Before I ask Dr. Sarkar to start, let me request all of you to keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Sarkar, sir, please share your screen and let us start the proceedings. Thank you.
Is the screen visible, sir?
Yes, sir, absolutely clear. Just press that hide, yeah. Please start, sir. Thank you.
Good evening. At the outset, I would like to thank sir for having invited me to this hallowed platform to present this particular talk. The first part of this discussion has already been carried out, where we have seen that the cystic kidney lesions can come in all kinds of flavors. So you have got these medical conditions, and you have got this, this particular neoplastic conditions. Neoplastic conditions usually you have got two entities which occur in children and quite a few that occur in the adults. Out of this, in the adults, one or two totally cystic picture. Sometimes they might have it, but often they present with a solid cystic kind of an appearance. So let's look into the pediatric pathologist first. So we have got two entities. The first one is pediatric cystic nephroma. The other is a cystic partially differentiated nephroblastoma. So going on to pediatric cystic nephroma, this is a particular tumor which is associated with DICER1 gene mutations. And this particular gene mutation is important because although this particular tumor is innocuous, in that recurrences usually do not happen once it has been excised, some of these patients might go on to develop DICER1 mutated related tumor, usual age group. And because the grow to large sizes and herniate into the pelvic axial system, there is a compression of the nerve fibers over there, resulting in pain abdomen often. The gross appearance is that these particular lesions are well circumscribed and you should not be seeing blastomal elements or immature stromal cells. We shall be coming on to the significance of the of those when we move into the next pathology, and that is cystic partially differentiated nephroblastoma. Now the name suggests a kind of an association with Weems tumor. However, this is not cystic nephroblastoma. This is an entirely different tumor, but it belongs to the spectrum of a tumor which starts from cystic nephroma, goes into CPDN and into the realm of cystic Weems tumor. The age group is even on a younger scale, so it occurs at around approximately 2 years of age and is usually a non-aggressive tumor. Radiologically, it might be difficult to distinguish between cystic nephroma, CPDN, and cystic Weems tumor. So the final say is by the pathologist after a diligent sectioning and in order to check for the presence of solid masses, because if you get even the smallest amount of solid component in this particular setting, it does not stay CPDN anymore. It becomes a cystic Weems tumor. So this grow up to large sizes up to 18 centimeter and have got a completely multicystic kind of an appearance without any solid expansile areas. So this is one of the cases which showed a large multiseptate, multiloculated cyst. So post contrast enhancement, there was a little bit of enhancement and the patient was started on a chemotherapy, although it is now agreed that many of these cases will not improve with chemotherapy and can go in straight for surgery. Even after chemotherapy, as we see in C and D, there has been no improvement. In fact, there has been a further thickening of this septae in both the kidneys. So once the surgery was done, the particular tumor that came up was this. So you had a multiloculated cystic tumor, and these multiloculated cystic tumors will not have any solid component. So you have only cysts, and the cysts separated by the thin papery septae. Okay, but there is a particular difference over here from the septations that we had seen in the case of cystic nephroma. So let's just compare them side by side. So if you see the pediatric cystic nephroma, you see that the cyst wall is papery thin. On the other hand, in the case of CPDN, it looks as if there has been a prominent thickening of this septa, as a result of which the large macrocystic morphology seems to have been replaced by a slightly microcystic appearance. And that is the most important thing about this particular entity. There will be a septal thickening. So we'll have to look into the microscopy to see as to why the septa is getting thickened in the first place. So if you see this particular case, you see that there are small cysts to larger cysts present over, all over the slide, but the septae are thickened, as you can see in these areas. So you have got these cystic spaces which are lined by hobnailed epithelium, but at the same time you have a very busy stroma. The stroma shows proliferation of spindle cells, immature spindle cells growing into intersecting fascicles, and at the same time it also shows these clusters of small cells with very high ANSI ratio and without any evidence of differentiation. So as you see, there's a color of these immature undifferentiated cells just around the tubules. So these are the cells with a very high ANSI ratio with molded nuclear contours. So these are the very immature primitive blastomal cells. If you look into the adjacent stroma, the spindle cells are seen to grow into fascicles, and they also have a pretty much undifferentiated look in that the cytoplasm is not really that much, and you have prominent mitotic activity as is seen over here. So this is the primitive mesenchyme. So we have got primitive blastema, we have got primitive mesenchyme, and at some places these blastomal elements are seen to form rudimentary tubular structures, as you see over here. So these are the primitive tubules. Compare these to the mature tubules where you see a healthy amount of eosinophilic cytoplasm in the cells lining the tubules. So over here you have a tubule which is surrounded by the premature blastomal cells, immature blastomal cells, and one or two immature tubules at the same time. So that's all that you will see in this particular entity. It will be a multilocular cyst. The cyst will be lined by flattened to hobnailed epithelium. But what's more important is what is going on in the septae which are thickened. So you get the blastomal clusters over there, you get primitive tubules, glomeruli, as well as the primitive mesenchyme. Again, there should not be any expansile masses in the cyst wall, because if you see a large, even a single solid focus within the cyst wall, it becomes a cystic Weems tumor and is not a CPDN anymore. So let's look at this particular case, which again to a slight extent resembles what we have seen priorly. However, as you see over here, there is that like it has got a multicystic appearance, but at the same time there is also a solid area which is seen over here. So it's not a CPDN. This is a cystic Wilms tumor or a cystic nephroblastoma. So once you get the gross specimen, that's what you see. You see that this is a predominantly cystic mass, but there is this single solid expansile mass which is sitting over here. So the diagnosis will be clinched by this particular, by this particular solid mass, because when you look at the wall of the cyst, it will have the same look as you saw in the case of CPDN. You will get the cyst wall which is lined by blastomal cells, embryonic mesenchyme, and the immature tubules. You have to section from the solid area. The solid area will not show you anything unique. It's going to show you the same things, only that you will get a proper solid mass with a huge conglomeration of all these of all these immature cells that you have seen. So if we are to make a snapshot of it, if we look at this particular cystic tumors with a predominantly cystic, with an entirely cystic morphology without any solid element whatsoever, you have got a pediatric cystic nephroma. On the other hand, if you have got a cystic tumor with appreciable amount of solid component in the wall, which is showing you a blastomal element, it's a cystic nephroblastoma. Sitting in the middle is this entity where you have the predominantly multicystic appearance, but at the same time you have these thickenings of this septa, and once you see it under the microscope, you get this blastomal element. So that is the cystic partially differentiated nephroblastoma. Now coming into the pathologies in adults. So we have seen the two entities in the case of pediatrics. In the case of adults, again you get the adult type of cystic nephroma, which is not the same as the pediatric cystic nephroma. You also have the mixed epithelial and stromal tumor, which again belongs to the same family as that of cystic nephromas. You have got this entity known as multilocular cystic renal neoplasm of low malignant potential, in short MCR NLMP, which has to be by definition an exclusively cystic tumor. You should not be getting any solid component at all. On the other hand, there is this provisional entity called a predominantly cystic clear cell RCC. Remember that 2 and 3 are both within the spectrum of clear cell RCC. Only entity number 2, that is MCR NLMP, is an exclusively cystic tumor, whereas this predominantly cystic one will look majorly cystic, except that on serial sectioning you will be finding small nodules sitting within the wall of the cyst. However, this is not this particular entity has not been listed in the WHO and the CAP nomenclature, so that needs to be kept in mind. Apart from that, you have got tubulocystic carcinoma and clear cell papillary RCC. Among these particular entities, clear cell papillary RCC is one which will often have a solid and cystic component. We cannot move into the realm of adult tumors until we talk a little bit about the Bosniak classification system. So this is a very elegant system. It was initially based on contrast enhanced CT, but the new revisions actually incorporate MRI definitions as well. So the basic approach is simple. You have an initial shot which is basically based on non-contrast CT, and you give contrast, and then you look at the degree of contrast enhancement within the mass. So if you have a measurable contrast enhancement, this goes into the higher categories, that is category 3 and 4. And if you do not get a contrast enhancement, these stay on the lower end of the spectrum, that is category 1, 2 and 2F. So this particular illustration will show a little bit about it. So if you have a measurable enhancement post contrast, you have the higher stages, that is category 3 and category 4. And the non-measurable contrast has the category 1, 2 and 2F. So in the category 1, you have a completely accepted cyst with a very pencil thin wall which cannot be appreciated well. In the case of category 2, you have got a few pencil thin septae, and this elongated cleft at the periphery is calcification. So sometimes you might get septal and wall calcification. In the case of category 2F, you have the septations increased in number. So you have multiple thin septae and minimal amount of septal thickening with or without calcification. By the time the lesion has gone into the measurable enhancement stage after administration of contrast, you have very thickened septae, which is the category 3. And once you have a solid expansile mass sitting in the soft tissue separate from the wall of the cyst, this is the category 4. Obviously, category 3 and category 4 are the ones that you need to be worried about. So if you look at this particular stratification system, as per the Bosniak approach, if you have a category 1 and category 2, you don't need to do anything further. No further evaluation is needed. Most of these cases will actually turn out to be non-neoplastic cysts. On the other hand, if you have a category 2F lesion, F stands for follow-up. So you will have to put the candidate in for a follow-up. Category 3 and category 4 are definitely surgical candidates, so you will have to consider surgery in those cases. So for example, let's look at a few of these examples. The first one is a category 1 lesion which has been screened by MRI. So you have you don't have enhancement over here, and you cannot see a proper cyst wall over here. So this is the category 1. In the case of category 2, which is present in B and C, you have a minimally appreciable cyst wall and very fine septae, which is almost inexistent. You see a little bit of hints of septae here and there. In the case of the category 2 renal cyst, again you have these particular septations which are not enhancing much after administration of contrast. In the case of category 3 renal cyst, however, you have a properly appreciable thick septa, whereas in the case of category 4 renal cyst, you have a proper solid expansile mass which is sitting separate from the wall of the cyst. So if we look at the various causes of adult renal cyst, like I told, category 1 and 2 will have mostly the hemorrhagic cyst, proteinaceous, post-traumatic cysts, etc. Whereas category 2F will have two important tumors, which are again towards the benign end of the spectrum, that is cystic nephroma and mixed epithelial stromal tumor. By the time it goes into category 3, again, one of the important culprits over here is CN and MEST, but sometimes in around 50% of the cases, you can get even the carcinomas presenting in this category 3. So you have the MCR and LMP, and at the same time, predominantly cystic clear cell RCC can also sometimes come within the category 3 entity. In category 4, you have a solid mass over here, so actually it should not be coming into the realm of the totally cystic lesions. So in that, you have predominantly cystic clear cell RCC, tubulocystic carcinoma sometimes, and clear cell papillary RCC. So if we are to totally incorporate all the pathologies that you can see in the adults, if you talk about the non-malignant ones, that is the category 1, category 2, 2F, and 50% of this category 3, category 1, 2, and 2F will have the totally non-neoplastic entities, whereas the categories 2F and 3 will have some of these benign tumors. In the case of malignant ones, 50% of the category 3 and almost all of this category 4 will have the malignant entities. So what about the pediatric cases? So in the case of the pediatric cases, Bosniak classification is not well applied. Actually, the thing is contrast cannot be utilized in that particular age group. So they have tried out a system where ultrasonography is done first, and then if you have suspicious US findings, that is category 3 and 4, then you go ahead with a CT scan or an MRI. In this particular system, you don't have a 2F category. However, this has not been tested comprehensively, and so the data on this particular approach is lacking, so we don't use this particular system of classification in the case of pediatric masses. So we now move into the adult renal tumors. The first one is adult cystic nephroma, which will kind of resemble the pediatric cystic nephroma. The only thing is that this is not associated with DICER1 gene mutations. The size range is again variable, starting from around 2 to 21 centimeter with an average diameter of approximately 7 centimeter. On sectioning, you will get a very well circumscribed cyst, which is unilateral and multiloculated with very fine, thin fibrous septae separating the various cystic locules. Surgical resection is enough, and the transformation to higher grade malignancies is uncommon. So in this particular case, again, you have got a polar lesion. Sectioning shows multiple thin-walled cysts separated by very fine septae, and the cysts are, and the cavities of these cysts are filled with clear glistening fluid. So if you see this particular slide, that's what you see. You see multiple cysts of varying sizes, and these cysts are lined by a very thin attenuated lining, attenuated to low cuboidal kind of a lining, which shows focal hobnailing at places. Now this is something interesting about this particular cyst. So if you see the wall of the cyst, you can make out this particular color which looks blue, just located around the wall of the cyst. Okay, so if you see, you have got this blue color, seen at many sites. So this is actually what we call the ovarian type stroma. Okay, so basically the stromal cells over here are very crowded, packed, and they don't have much of eosinophilic cytoplasm. They are usually slightly ovoid to slightly elongated cells with scanty cytoplasm, which is why they overall give us a blue kind of a look. So if you compare it with the normal ovarian stromal cells, that's how they look. However, not all cases of this cystic nephroma will have this particular blue color. Like for example, this particular case where you have multiple cysts of varying sizes, again lined by the same monolayered, attenuated, bland cuboidal kind of an epithelium, but you don't have that blue kind of a stroma over here. In fact, you have some mild amount of hyalinization setting into the wall of the cyst. Here we see a little bit of hobnailing over here. we don't see much of a clear cell change over here, because had we seen significant amount of clear cell change, it would have actually gone towards the spectrum of the clear cell RCC, that is the multilocular cystic renal neoplasm of low malignant potential. So this is a biphasic tumor in which you will get multiple cysts of varying sizes separated by thin fibrocollagenous septae. And sometimes you might get the ovarian stroma. IHC is not really useful in this particular case because morphology, the gross and the microscopic clinch the diagnosis. The mixed epithelial and stromal tumor actually belongs to the same family of tumor along with CNs. The age group is 50 to 60-year-old age group. It is benign, but there is a potential for malignant transformation, both sarcomatous as well as carcinomatous. And here, rather than a cystic appearance, what you have is a cystic solid appearance. Often the solid component will be present in good amounts. We shall see why. The size range is around 4 to 6 centimeter again. So it's got a solid cystic kind of an appearance. So in this particular case, if you see, this is a Bosniak 3 category lesion where you have a proper thick septae which is thin, which enhances after administration of contrast. So we have to see as to why the thickening in the septa has happened in the first place. So if you see the gross appearance of this particular tumor, you see that it's probably apt to call it a cystic solid tumor because the septae have actually got pretty much thickened to the point that the cysts have actually got narrowed down to smaller cystic spaces. So now we'll have to see why, as to why the septa has got expanded. So if you look at this particular slide, you see that there are multiple cystic locules of varying sizes, but at the same time, you also have a thickening of the septa which is seen throughout. So if you look at the cysts, it's the same as what you had seen in the case of cystic nephroma adult type. That is, the lining is the same usual cuboidal to slightly hobnailed kind of epithelium. But the interesting thing is what is happening in the septa. So you are having a lot of fibroblastic proliferation happening, which is why the septa has got thickened. The cells which are present within the stroma, although they are proliferating in exaggerated amounts, they are bland, they are not having much of pleomorphism. Mitotic activity is also not prominent. So this is one of the cases. The other case is one where you have cysts of varying sizes. The cyst wall, that is the septae, are thickened, but over here you don't have much of a cellular stroma, but there is a thickening. So towards the periphery, you get the compressed renal tubules, and here in the septae, you see that there is a thickening, but the thickening has been actually because it has been probably there for a long period of time, and there has been hyalinization that has set into the wall of the cyst. Whatever it is, if you compare the adult cystic nephroma to the MEST family, you will see that both belong to the family of cystic tumors. However, in the case of cystic nephroma, the cysts are actually much more conspicuous, whereas in the case of MEST, the fibrocollagenous septae are actually thickened to the point that the cysts sometimes can look like a minor component. So you often get a solid cystic kind of an appearance in the case of MEST, which is why between the two, MEST often tends to segregate into the category 3. Okay, so that's all you see in the case of microscopy. We have already talked about it. Sometimes you might get ovarian stroma over here, just like you see in the case of adult cystic nephroma. Now coming on to this interesting entity, that is multilocular cystic renal neoplasm of low malignant potential, in short MCR NLMP. So this belongs to the family of clear cell RCC, like I've said. The VHL gene alterations can also be seen in this particular family of tumors. The most important thing is that this particular lesion has to be completely cystic. You should not be getting any solid component whatsoever, because if you get a solid component, usually which is appreciable at the time of grossing, it does not come into this entity, it will go into the predominantly cystic category, which is something separate. The good thing about this particular entity is that more than 80% of the cases will present with stage PT1 disease, and there is no history of recurrences or metastasis which is seen in these particular tumors. They are very, very well circumscribed lesions with a fibrous pseudocapsule, and they have got a completely multicystic appearance without any solid or expansile masses whatsoever. So that is how the cyst will look like. So this particular cyst, sorry. So can I just close one app for a second? Is the screen seen, sir? Okay, so you have an exclusively cystic tumor which is comprised of multiple cysts of varying sizes. The wall of the cysts is lined by a thin layer of bland cuboidal.
Yes, please, no issue.
Is it audible, sir? Hello? Hello? Is it audible, sir?
Yeah, it is audible. It is audible. Please go ahead.
Okay. Okay. So the wall of the cyst is lined by clear cells over here, which is why it belongs to the family of clear cell RCC. So if you see, you can appreciate the fact that good amounts of cells are actually having healthy amount of pale clear cytoplasm. And the nuclear features are low grade. Obviously, we will go into a higher power to appreciate the low grade features. So let's talk a little bit about the nuclear grading in this particular in this particular tumor. So as per definition, nuclear features have to be low grade over here. So the WHO ISAB grade has to be 1 or 2. In fact, if you look at Fletcher and Bostwick, they're even much more stringent, saying that only nuclear grade 1 will do in this particular group of tumors. So as you see, the cells are not having much of prominence of nucleoli, so they are belonging to the grade 1. They are clear cells though, and they are predominantly clear cells which are lining these cysts. And also within the hyalinized septa, focally you have these small nests of clear cells, but there is no expansile growth. These small nests are just freely floating around within the septa, and they are not forming a discrete mass. So let's look at this particular case. Again, you have got a multicystic kind of an appearance, and the wall is lined by the clear cells with low nuclear grade. And if you look at the septa, there are these small nests of clear cells, very small nests, and there is no expansile masses. So that's all you will see in this particular tumor. You will get at least one layer of clear cells with very low grade nuclei, sometimes forming small clusters within the septa. You should not get necrosis, vascular invasion, etc. You should not get the characteristic linear arrangement away from the basement membrane of this nuclei. We will look into that subsequently, because that would suggest a clear cell papillary RCC. And most importantly, most importantly, there should not be expansile or solid growth within the wall of the cyst, because in that case it jumps into the next category, that is the predominantly cystic clear cell renal cell carcinoma. Now this particular case it probably needs a little bit of discussion, because it was put up as a predominantly cystic clear cell RCC. So let's have a look at this particular one. You see a multicystic tumor where you have these cysts which are lined by a single layer of clear cells with low grade nuclei. So you are just rolling your slide along and seeing that the feature is more or less constant. And then all of a sudden you hit a particular focus where you see that there is an expansion in the wall of the cyst. And this expansion has happened because of the coalescent nests of clear cells. And if you look at higher power, they have got probably grade 2 nuclei. Again, you see the rest of the slide, you come to another focus where the wall of the cyst seems distended by a back-to-back coalescent proliferation of these nests of these clear cells with grade 2 nuclear features. So what do you call it? I think this is a pretty dicey case. So before that, let's talk a little bit about what actually constitutes the threshold where you will call something MCR NLMP, and where you will jump into the next step and call it a predominantly cystic clear cell RCC. So this particular journal article has summarized the issue well. The first one, that is the A and B, shows the MCR NLMP, where it's a exclusively cystic tumor without any expansile element whatsoever. But the other one, probably serial sectionings have shown in the next family of tumors, you have this small yellowish nodule which is sitting in the wall of the cyst, which once you are putting under the microscope turns out to be an expansile nodule. So the advice that the thing that I would suggest the first years would be, in such a case, probably before hair splitting a lot about whether it's MCR NLMP or predominantly cystic clear cell RCC, go back to your grossing table, take out the specimen. Maybe the thing has been done in a hurry, maybe the sections haven't been thin enough, and if you diligently section it well enough, maybe you will come across this particular solid nodule which is sitting over here, and in that case your diagnosis is pretty simple. Having said that, one of the authors of this particular article is also the primary author of this particular multi-institute study, where they have actually segregated these two categories of tumors. My query was as to whether you always need a gross equivalent to call something as a predominantly cystic clear cell RCC. So in this particular article, inclusion criteria were two. Firstly, you could include the grossly discernible nodules, but also those microscopic nodules which did not fit into a 20x field of view. So this is not a standard field of view in our usual microscopes, but I guess more than one low power field is not that big a size. So probably a microscopic definition also is enough for this particular tumors, wherein you have a thickening of the septa, which can be seen microscopically as an alteration of the configuration of the septum. Okay, so even those microscopic ones have gone into this category of predominantly cystic clear cell RCC. So I looked into the literature, and the definition for the expansile nodule actually varies across multiple types of articles. So the overwhelming majority say that you need to have grossly discernible nodules, and the size cutoff seems to be around 0.5 centimeter. But even microscopically, if your nodules alter the natural configurations, I mean, that is, you have a thin septa which is all of a sudden expanded by this nodule, then also it might fit the definition. So our case priorly might fit that particular thing, but I'm not very sure whether everyone would call it a predominantly cystic clear cell RCC. Little bit of talk about why we need to hair split a bit between MCR NLMP and a predominantly cystic clear cell RCC, because the T3 stage presentation is more often seen in the case of the predominantly cystic clear cell RCC, and so there is a slight worse progression-free survival in those cases. Having said that, both the MCR NLMP and the predominantly cystic clear cell RCC have got an overall better prognosis compared to the usual conventional non-cystic clear cell RCC. So again, if you have to make a snapshot, if you see an adult renal tumor of the RCC family which is composed entirely of cyst, you will think of a multilocular cystic renal neoplasm of low malignant potential. On the other hand, if you are doing diligent grossing and you are coming across small nodules which are seen in the wall of the cyst, and if you are seeing under the microscope and you see that they are forming an expansile nodule of RCC, even if it's a single focus, go ahead and call it a predominantly cystic clear cell RCC. Having said that, once you are about to sign out the particular case, I guess you will have your WHO Blue Book and the CAP protocols in hand. You will be surprised when you come across the fact that neither of those two actually have a mention of this predominantly cystic clear cell RCC category. So they do not recognize this particular family. I have had only one such case that I have dealt with, and in that case I had actually called it a conventional clear cell RCC, but I had given an elaborate note stressing on the predominantly cystic nature and the fact that it might have a better behavior, because the clinicians more often are actually conversant with the two extremes, that is the MCR LMP and the conventional clear cell RCC. So if you are giving out this particular diagnosis, it might not make much sense to the treating clinician. Coming to the clear cell papillary renal cell carcinoma, again, like I said, it can have a cystic appearance, but sometimes it will have a cystic solid appearance at the same time. This is a variant within the RCC family, which has a very, very benign course of behavior. It's usually very small in size, with the mean size being around approximately 3 centimeter, and very indolent behavior. It's a very well circumscribed lesion and can show a significant amount of cystic change. So before we go into the microscopy, little bit about the most interesting thing about this particular tumor. So let's look at this conventional papillary RCC. So if you have a look at it, you see that these nuclei are nicely polarized, sitting on the basement membrane and pretty much separate from the apical surface. On the other hand, if you look at the clear cell papillary RCC, you see this unique pattern. The nuclei actually appear pushed out from the basement membrane and going towards the apical surface, and that is something which is seen diffusely in a linear fashion and involving all of these nuclei. So this is something very unique about the clear cell papillary RCC. The same issue about clear cell papillary RCC versus a clear cell RCC, because you know the clear cell RCC, although the usual pattern is acini and nests, sometimes you can get a focal papillary kind of an architecture, and sometimes we might be biased thinking then, okay, I mean, it has got a clear cell morphology, there are papillas, so could it be a clear cell papillary RCC? But it's not the case, because as you see, firstly, the papillae are not having any vascular core, and at the same time, the nuclei are actually resting on the basement membrane and have not migrated towards the apical surface. Whereas in the case of the clear cell papillary RCC, you have a significant shift of these nuclei from the basal aspect towards the apical surface. Also note one important fact, that at the areas where the papillae are becoming appreciable, in the case of clear cell papillary RCC, often the papillae will not be very, very conspicuous. Actually, the commonest pattern is compressed coalescent acini, and where the papillae are seen, you might not actually be able to appreciate that particular fact that the nucleus has moved away, simply because the volume of cytoplasm seems to be less in those areas, in which case you will definitely have to go in for an IHC. So let's look at this particular case. So this was a cystic tumor, but again there was a cystic solid appearance with a solid nodule within the cyst. So if you look at the solid component, you see that towards the left you have got this coalescent acini almost collapsing into each other, and if you see the lining, you will see that these nuclei are all pushed out from the basement membrane and all moving towards the apical surface, which is the characteristic presentation in the case of clear cell papillary RCC. It's got a unique presentation that way. However, in the areas where it has become actually papillary, like the cells are having less amount of cytoplasm, and you are not able to appreciate that particular distinction well. In the other case, again, this is a solid kind of tumor, but with some amount of cystic change within it. Again, if you see the collapsed acini which are seen over here are having the characteristic presentation of this nuclei pushed out from the basal aspect and going towards the apical surface. The third case, where again you have a cystic solid kind of a tumor. If you look into the solid component, however, you run into that particular problem. Here you are not getting much of those acini, rather you are getting these papillary structures. And given the fact that in the papillary areas you will often be not seeing that much of appreciable volume of cytoplasm, you are actually a doubt at whether you are seeing a type 1 papillary RCC, which will often have low grade nuclear features. And as we know, cystic change is often seen also in the case of papillary RCC. So you look closely at some areas, you have a feeling as if as if nuclei are getting pushed towards the luminal aspect focally, but it's really nothing that you can actually bet on. Okay, so in this particular case, you will definitely have to use IHC, and you will have to consider a basic panel comprising of CK7, carbonic anhydrase 9, CD10, as well as racemase. So what CK7 shows is a diffuse positivity present in a pan-membranous pattern throughout all the cells. So that would be something that would be seen in the case of papillary RCC as well. But the interesting thing happens when you do a carbonic anhydrase 9. So if you do a carbonic anhydrase 9, you see that there's this particular pattern which is pretty characteristic. That is, this particular stains the basal as well as the lateral aspect of the cell. But if you look at the top, it appears that the top does not stain that much distinctly. For example, if you see the right hand side picture, you will see that there is a dark accentuation of the staining at the base and at the lateral aspect, but the top appears to be free, just like a cup. On the other hand, if you do the markers for papillary RCC like CD10 as well as racemase, you see that they turn out to be negative. So IHC is important in this particular way, in this particular tumor, because the PRCC separation from this particular family is very important. In the case of papillary RCC, you will have a diffuse positivity for CK7, but you will not have a positivity for this carbonic anhydrase 9. At most, you will have a focal patchy positivity. And if you do CD10, you will have a positivity towards the canalicular surface, apical membrane kind of a positivity. And the racemase AMKR, if you do, you see a diffuse positivity over there. The second issue, again, like I said, sometimes a clear cell RCC can have areas where there is a faint kind of a papillary architecture, and you have the issue of clear cell papillary RCC versus a clear cell RCC with pseudo clear cell with the pseudo clear cell papillary RCC like areas. So in the case of a conventional clear cell RCC, you get these collapsed coalescent nests of clear cells. So that particular architecture usually will be there. So that is one important aid. And at the areas where you have a little bit of papillary architecture, you don't see vessels in the wall of this papillae and the lining. So you have to appreciate the fact that the nuclei are all placed basally, and there is a healthy amount of space between the nucleus and the apical surface, unlike what you see in the case of clear cell papillary RCC. And if you do IHC with carbonic anhydrase 9, you have a positivity, but this positivity is seen to encompass the entire circumference of the cell. So what you get is what we call a box-like positivity. And in the case of CD10, you again get that apical membrane positivity, which is not seen in the case of clear cell papillary RCC. So that's all about clear cell papillary RCC. So it's a particular tumor which often has a cystic component. It will be mostly, although the name is papillary, the most prominent pattern that you will see are actually collapsed acini, but you will get focal papillary differentiation here and there, which might not be that obvious, and you will have to definitely consider IHC in order to separate it from the papillary RCC and those cases of clear cell RCC which might have a focal papillary-like pattern. Coming to the tubulocystic carcinoma, this is exclusively cystic. So by definition, it should not have solid component at all. The unique presentation is what has been described as a bubble wrap kind of an appearance, and that is how it actually looks. It looks like those clear bubble wraps which are present over the, which are usually seen in the packages. And you have multiple variable size cysts filled with clear serous fluid. Most of them are very small, usually PT1 stage. They will not have solid areas, and the mean size is around 4 centimeter approximately, with a strong male preponderance. So let's look at one of these cases. So as you see, it's a pretty small tumor, and it's a very, very well circumscribed one at the pole, and the adjacent kidney shows some amount of interstitial inflammation. So if we look at this particular tumor, the predominant pattern seems to be tubular and cystic, that is small tubules and larger cystically dilated tubules. And that's all. You don't have any solid kind of a pattern whatsoever. It's all separate tubules and cysts. So if you look at the lining of the, of this particular tubules and cysts, you will see that they're lined by a monolayered cells with pretty much conspicuous nucleoli. So that's one important thing. Nucleolus becomes prominent in this particular tumor, nucleolus. In this second case, again, you have a very well circumscribed tumor, which is again composed of mostly tubules and some cystically dilated tubules. And these cystically dilated tubules are again lined by hobnail kind of an epithelial cells, which are often seen in this particular case. And these hobnail cells have prominent nucleoli, like I said. So nucleolar prominence is an important feature in this particular group of tumors. You don't really need too much of an IHC because the presentation as well as the microscopic appearance is pretty unique. However, you have to take care that you are excluding a solid component, because if you are seeing a solid component with this particular histology, we are aware that this particular entity exists. So hereditary leiomyomatosis associated RCC can have fumarate hydratase expression which is lost, and those will have this kind of architecture along with a solid pattern at the same time. So maybe if you are considering IHC and if you have access to it, you might consider doing fumarate hydratase expression IHC. So the lining is a single layer of flat hobnail cuboidal cells with prominent nucleoli, and there should not be any solid pattern whatsoever. So acquired cystic renal disease associated RCCs are predominantly cystic, but they have nodules of RCC which are present within the wall of the cysts. They are well circumscribed and usually they are incidentally discovered, but they have got something unique about them. Like, let's look at this particular case. So you have a cyst which is now been obliterated by a solid tumor, and if you look at this particular tumor, it gives us mostly a cribriform sieve-like kind of an appearance. However, at the same time, you are also seeing significant amount of blotchy calcific deposits in the background. So if you are seeing over here, all these microcystic spaces seem to be having a lot of calcified material within them. So there's the oxalate crystals which are getting deposited over there. And the lining cells are actually having abundant amount of voluminous cytoplasm, eosinophilic. And again, nucleolus is very, very prominent in these cases. And the pattern is cribriform. So that's all that you will get in this particular family of tumors. You will get a cribriform sieve-like pattern. You will have large cells with abundant eosinophilic cytoplasm, prominent nucleoli, and intratumoral oxalate crystals. Now, an honorable mention goes out to this particular entity. It's often not stressed on enough, but I have seen 2 of these cases, and I think it's important to discuss this particular tumor within the family of the cystic renal tumors. So primary renal synovial sarcoma often is predominantly multicystic kind of an appearance in around 2/3 of the cases. So if you look at your Sternberg, there's a nice illustration as well as description of that fact. Unfortunately, Ackerman does not really highlight that particular thing. The age group is from the from 20s to the 50s, and most of these patients will have a very, very advanced kind of a disease. This is unlike the other cystic renal tumors where you usually have a T1 kind of a disease. This is usually very, very advanced presentation with an increased incidence of pulmonary mets and even lymph nodal metastasis. So this particular case is actually not one where I want to show the cystic kind of an architecture, but just to highlight one particular fact. So this is a primary renal synovial sarcoma with a solid pattern, but at the same time, within the solid architecture, you get these slightly cystically dilated spaces which are seen scattered throughout. These are actually the native renal collecting ducts which are caught within the wall of the, which are caught within the tumor, and sometimes, often actually, these collecting ducts will grow up to grotesque sizes, giving rise to a kind of a cystic appearance, although they are not a part of the tumor per se. So this is a fact that has also been mentioned within Ackerman. And if you look at these entrapped cystic structures, you see that they are lined by the normal hobnail kind of cells that you see in the normal cortical collecting ducts. And Outside, you have the main tumor sitting over here, which is comprised of intersecting fascicles and sheets of this mildly pleomorphic spindle cells with scanty amount of cytoplasm with prominent mitotic activity. And over here, it gives a kind of a what Enzinger calls a kind of a marbleized appearance, a kind of a heterogeneous appearance where you have hypo as well as hypercellular areas. So that might create an issue with a malignant peripheral nerve sheath tumor sometimes, because even that particular tumor looks like synovial sarcoma and has that kind of hypo versus hyper areas. And at the same time, if you were to see hemangiopericytomatous like vessels within this context, if you were to get staghorn vessels within this particular background, again, hemangiopericytoma cellular ones would also come into a differential diagnosis. So you might consider a panel which includes PAN-CK, EMA, low molecular weight cytokeratins, CD99, and if you think it will help, BCL2 along with TLE1. For MPNST, you could consider Asst with your Soxton. And for solitary fibrous tumor, in those cases where you have those prominent vascularity, consider CD34, and if you have it, STAT6. Now, having said that, these particular sarcomas can often have a very cystic presentation simply because the entrapped ducts grow up to huge grotesque sizes. Let's look at the next case, in which you have a predominantly cystic tumor. So you see multiple cysts of varying sizes which are separated by septae which are thickened and expanded. These septae look very blue, very, very cellular. And if you look within the expanded septae, you see that there are these short fascicles and sheets of these spindle cells, which kind of look mildly pleomorphic. And there is one interesting thing over here. You are seeing a significant population of mast cells as well. So presence of mast cells within a low-grade spindle cell sarcoma is often suggestive of a synovial sarcoma. So that's another interesting tidbit that will probably help sometimes. So you consider IHC, PAN-CK, you might consider PAN-CK, but again, PAN-CK will often not help you much. Probably you are better off doing a low molecular weight cytokeratin or a HMW-CK. EMA comparatively is helpful compared to PAN-CK because it often tends to stain positive in increased amounts compared to your AE1, AE3 cocktail. On the other hand, CAM 5.2 would help to pick up a larger number of cells. CD99 could be utilized, but again, it is not very specific. TLE1 is the new marker which is talked about. It is pretty much specific for this particular tumor. However, MPNST can also show expression with this particular marker. And if you are finally caught up even after doing all these IHCs, you could always send the block for a fish to check for the SS18 and SSX fusion. So we are almost done with the entire family of tumors that we have discussed in the context of the cystic kind of tumors in the kidney. However, for the first years, I'd just like to end this particular talk with an important observation as to the fact that in your routine practice, probably you will come across renal tumors which have quite a lot of cystic change, but you should not actually include those within this particular family, because all the RCCs are known. RCCs as well as WHIM tumors sometimes can have extensive amount of hemorrhagic change, necrosis, which will subsequently lead to a so-called cystic appearance. However, those are actually pseudocystic malignancies which should not come into a differential diagnosis when you are talking about a cystic pattern tumor. For example, like in the case of papillary RCC, sometimes you can get a tumor which is so cystic that you have only got small amounts of tumors which are kind of sticking to the wall of the cyst. You have to observe and give importance to the fact that the cystic change that you are seeing over here is actually because of all these secondary, what we call regressive changes, that is hemorrhage, necrosis, etc., which is set into the tumor. And because of these secondary changes, you are having a so-called cystic appearance, but that does not make your tumor a cystic one. If you look at the solid component, you will see that this is the conventional papillary RCC, where the cells are having grade 2 nuclear features, along with the fact that you can see these macrophages within the core of the cyst, within the core of the papilla. This is another case where again you have a cystic tumor but with a little bit of solid component. Again, you will have to exclude a type 1 papillary RCC in this case, because sometimes the papillae might not be very well developed. Again, it might be mostly coalescent tubules over there. Although you will see focal kind of a papillary differentiation, and in these cases you will need to do an IHC, because at some times you might have a problem with a clear cell papillary RCC. And again, a conventional clear cell RCC can have extensive amount of secondary cystic change as to make it look cystic. But again, if you are seeing all this regressive change happening within the tumor in the form of hemorrhage, necrosis, etc., you should not be reporting, or you should not be even thinking about that family of cystic kind of tumors that I talked about, because this is just a conventional clear cell RCC which has got extensive amount of secondary cystic change because of hemorrhage and necrosis, etc. So you'll just pay attention to the fact that this has got this solid component which has got the conventional appearance of a conventional clear RCC. So you will report it as a conventional clear cell RCC. And lastly, sometimes Weems tumor can show extensive amount of cystic change. However, in my experience, I have not seen any case of Weems tumor where the cystic change was so marked that there was actually an issue for segregation from CPDN. Most of the times, the cystic change usually happens secondary to chemotherapy which has been given prior to the operation. So that's another important thing to keep in mind. And of course, you will have a significant amount of solid component in such cases, which will give you the blastomal elements, etc. That is your usual triphasic histology. So that should not be a problem in this particular case. So to summarize, the multicystic renal lesions have got a spectrum of entities, which include both non-neoplastic as well as tumoral entities, and this can be pretty much overlapping in that the non-neoplastic entities with the passage of time can look similar across groups. On the other hand, neoplastic cystic lesions can also show significant amount of morphologic similarity. You have got diverse classification schemes. However, there is no single one-size-fits-all solution. So for every case, you will have to have a fresh approach. I would suggest to the PGs that you pay diligent attention to grossing. In my experience, oftentimes the problems that we talk about as far as microscopy and your classification problems are resolved by a simple trip back to your grossing station, where diligent sectioning sometimes shows that your tumor is something entirely different. So I'll end this particular discussion with a little bit of mention of these very beautiful slide sources from which I've sourced my cases. These are sources which are advisable to the PGs for their self-learning. There are a lot of interesting cases, and in fact, most of the entities given in the textbooks, you can come across in those sites. You just have to look for them. That will be all. Thank you.
Thank you.
Thank you.
Wonderful presentation. So nice. Fantastic speaker.
Thank you.
Very, very nicely done, and very nicely you took us through all the lesions, right from the pediatric group to the adult, from the cystic to the cystic solid to the solid ones. And you rightly said in the end, the last two slides, sums up the whole presentation.
Yes.
One size does not fit all. That's number one. And with my little experience of nephropathology,
yes,
I 100% agree with you that the grossing station part is very important.
Yes.
And I've seen so many of these nephrectomy specimens with my experience in Fortis.
Yes.
And every time there is an issue, you go back and see the gross, and that is where the solution lies.
Yes.
And for teaching purpose, we all try to teach, as if to say these are watertight areas, and this is one entity, this is another entity.
Yes, sir.
But the complicated part of the thing is that in one tumor, there are a lot of entities which are, there. There's some cystic component, there are solid components, there are clear components, there are clear cells with papillae components, and it is there where your theory, your knowledge, your experience, the way you see a slide really matters.
Yes.
Dr. Mitadru, you are a fantastic teacher, I can tell you. Very good teacher.
Thank you, sir.
You have really done wonderful. And since we have this scheme, of having all these recorded on YouTube, and that would be there for time immemorial, this presentation would really stand out as one of the best presentations I have heard on cystic neoplasms of kidney, both the non-neoplastic as well as neoplastic. And for all the PGs who will be listening to this, this would be a very nice teaching, learning, and training exercise. I really thank you so much from the bottom of my heart for coming on this platform, gracing this occasion, taking out so much time. You are such a busy person, and teaching us this entity. Thank you so much.
It was my pleasure. And in the end, I would also like to thank you for this particular project that you have initiated. I could not actually imagine that something of this huge size could be done. Actually, from my point of view, it's is very, very important for those people like us who are just starting out. In that, when we are faced with an issue, say things like quality, hemat, etc., we know where to look into. So I have found lots of practical issues which are actually covered in these discussions of yours. So thank you from my side, sir.
Thank you. It's so nice to hear that, And just for the information, your lecture is lecture number 202. So 202 lectures covered up till now on
Yes.
this platform.
Huge number.
Thank you so much. Please share the PDF. We will share it with the with the students on the Google Drive.
Sure, sir.
And my sincere request to you is maybe a month later or maybe 2 months later, please come back on the platform again and teach us something new.
Sure, sir.
Take
Sure,
care,
sir.
Dr. Mitadru. Again, before closing, let me tell you, you are a wonderful teacher.
Thank you, sir.
Excellent. Thank you so
Thank you,
much.
sir. Good night, sir. Bye.
Bye. Good night. Take care. Bye.
Yes.